We're going to now hear from Dr. Carrie Frenette, who is our Medical Director of Liver Transplantation at Scripps. And for those of you who don't know, Carrie joined us a number of years ago and started a Center of Excellence for Liver Cancer. And that's now part of the MD Anderson system at Scripps. And she runs a tumor board that evaluates 20 new cases a month, and really has made this into a science, and it's really the way to go. Before she came to us, we all managed liver cancer kind of willy-nilly, independently, and now it's done the correct way by a group that's multidisciplinary and that knows what they're doing. So anyway, Carrie, thank you so much for presenting the abstract.
Thanks, Paul. And I really have to compliment Rich on a really fantastic review of a lot of new data. So thank you for doing that. So my job was to talk about the abstracts from AASLD, which I always find to be really difficult to do a review in a short period of time, but I'll do my best and I'll try to not get too all over the place for us. I thought the way that I would do this is to really split it by the BCLC. And Rich, explained that this is really where liver cancer staging and treatment is right now. And when I think about abstracts that I'm looking at and research that I'm looking at, I sort of think about where is the patient at in their cancer life. Are they in the early pre-cancer development? Are they early stage, advanced, whatever? And we know that patients change stages and do stage migration. So that's how I decided to split out the abstracts. So we'll start with talking about things before the patient even gets cancer, because I think that's where and I'm going to spend most of my time on that because I think that's where a lot of you guys end up seeing more patients, right? We're trying to think about this. So a couple of interesting abstracts came out, and patients always ask me, what can I do to prevent myself from getting cancer? And I thought this was a really interesting study that looked at over 120,000 adults as a nationwide prospective cohort study. And they actually looked at healthy lifestyle and the impact of healthy lifestyle on the incidence of liver cancer and cirrhosis-related mortality in adults. So they defined a low-risk lifestyle or a healthy lifestyle, and they had 5 factors. So they looked at people who either never smoked or smoked less than 5 years, had either no alcohol or moderate alcohol use, had a normal BMI, did weekly physical activity at least 120 minutes, and had what they considered a healthy diet. And these patients did routine questionnaires to really answer this. So what they found when they looked actually at patients who had all 5 risk factors versus none of the risk factors, the risk for incident liver cancer was 3.59, and for cirrhosis-related mortality was 4.27. So that really tells us that there's a huge impact that patients can do with their lifestyle modifications, and these are risk factors that the patients themselves can modify now, okay? The biggest population attributable risks, meaning how much cancer was actually related to each one of these things, was obesity, BMI of over 25. And they actually realized that 36% of all liver cancer is directly caused or related to obesity. And what they actually also looked at and discovered was that if we had all patients in the U.S. have all 5 of these healthy lifestyles, we would actually be able to prevent about 90% of the liver cancer in the U.S. So it really impacted to me and made me realize how important it is really to talk about to our patients about the healthy lifestyles. So the other thing that was interesting, and this was another database study, they actually looked at the impact of race. And we've always thought of race and ethnicity as liver cancer risks being what their risk factors are, okay? But they actually looked at this, and they split out the different races of almost 500,000 patients with cirrhosis based on ICD-9 codes. Now, there were population differences. For instance, African American patients had much more hepatitis C than the other races. Asia Pacific Islanders had much more Hep B, as we would expect, also had more smoking, 18% smoking, whereas the other races was 3 to 5%. And Native Americans were more females, more obesity, and more alcohol. okay, well, so we expect the rate of liver cancer to be different based on these underlying risk factors. But what they actually found when they adjusted for risk factors, including obesity, alcohol, tobacco, Hep B, Hep C, and diabetes, Asia Pacific Islanders, when all of that was normalized, had a 3 times higher chance of getting liver cancer. So there's something in ethnicity, which is probably somewhat related to genetics, that increases the risk of development of liver cancer. So this is something that I'm going to be thinking about when I'm screening my cirrhotic patients. So another thing that's interesting in terms of trying to prevent liver cancer, so there was this interesting study that looked at carvedilol use. So we know that carvedilol is a non-selective beta blocker that is not completely non-selective, but can be used for variceal prevention, or variceal prophylaxis, I should say. But there's been some data coming out about carvedilol use and other malignancies, including upper GI tract and lung malignancies. So what they actually found was that in 174,000 patients with cirrhosis, the incidence of HCC was actually lower in the carvedilol group compared to propranolol, nadolol, or non-beta blockers. So it was about half the rate in people using carvedilol. So they actually looked at the odds ratio, and the risk of developing liver cancer was actually 25% lower in patients with carvedilol. However, if they looked at patients who were using it that had varices, that benefit went away. So the patients who had cirrhosis but no varices and were on carvedilol for some other reason, they actually had the benefit. But if they were using it for variceal prophylaxis, there wasn't a benefit seen. So I can't explain why that is, but I thought that was really interesting. So looking at surveillance, so we're all thinking about how to screen patients, and there's been a lot of data coming out about screening and is it worthwhile and how to do it appropriately. As you know, there was a paper in, was it Annals, that said that cancer screening for liver cancer wasn't appropriate. But we all know and have seen that this is beneficial. But this was actually looking at a cost effectiveness and cost acceptability, looking at this Markov model. And what they actually found is that looking at cost acceptability of no surveillance, not great, but when you looked at the combination of ultrasound and AFP, there was a cost effectiveness and cost affectability. So this is really something that not only is it good for our patients, but it's also cost effective to go ahead and screen them for liver cancer. Now we have to think about the patient side of this, right? So we all know we need to screen, and there's been lots of information about how it's not great at getting people to be screened. Some of it's, patients aren't coming in. Some of it's doctors are too busy to remember to order it. There's lots of different reasons. But this was actually a survey that was done of over 1,000 patients that asked the patients, what do you think about your liver cancer risk? What do you think about your liver cancer surveillance? And 74% of patients with cirrhosis in this study thought that they were somewhat likely to get liver cancer in their lifetime, and that they thought it was really important to have surveillance. Now, unfortunately, less than half of them actually got their surveillance, even though it was ordered. So even though patients were worried about cancer and thought they were somewhat likely to get it, they weren't getting their ultrasounds. So they asked why, and a third of them, it's cost of the test. They're worried about copays. They don't know how to schedule it. They don't know where to go. They can't get to the ultrasound, okay? So, when we're ordering these tests, we need to think about it from the patient side and figure out how to make it the easiest that we can so that patients are actually able to complete this testing. Over 90% of these people had medical insurance, and that wasn't the issue, but they had a lot of financial burden because of their copays. They delayed care because of cost. They had to borrow money, went into debt, or had significant worries from their medical bills. Okay, so when I'm ordering surveillance on my patients, I discuss with them. They ask me about copays. I tell them, I don't know a lot about your copays, but if they tell me, hey, my copay is $100 if I do it at this place, and it's $20 if I do it at that place, I try to work with them. So I just want you to remember the financial burden to the patient really is going to make a difference, and this is in everything that we do. Now, once you have someone that you have a mass and you're working it up, we also have to think about that there are diagnostic and treatment delays, okay? So this is something I always worry about. I don't like to see, oh, this guy had a mass on his CAT scan that he had in the ER 3 months ago, and he's just now getting to us where we're seeing him and working him up and treating him. So this study looked at 925 patients who were diagnosed with liver cancer from 2008 to 2017. A third of them were diagnosed as a result of surveillance. The rest of them were either incident HCCs. They went to the ER with a sore elbow and got a CAT scan and found a cancer. I've actually had that happen. Or they came in with symptoms, okay? So the median time from presentation to actually getting the diagnosis was 7 days, but 1 in 5 patients had a diagnostic delay of over 60 days, over 2 months, okay? The median time from diagnosis to actually getting treatment was about 1.5 months, but a third of them had a treatment delay of over 60 days, over 2 months. So a lot of patients actually are having diagnostic and treatment delays, which gives me a lot of anxiety when I'm thinking about my patients. Now, interestingly, the treatment delays were actually not associated with an increased mortality risk, which I thought was fascinating. And I'm going to show you the next study, which is, I think, why that is. But they did see that the delays did result in stage migration in a subset of patients where they went from a potentially earlier stage of disease to the next stage of disease, which then can affect their curability or potentially other treatment options that we can give to them. Now, part of the reason that some of this might not be, a big deal is because of the growth rates, okay? And, I think that a lot of times we talk about cancer and people ask me, like, how fast is my cancer growing? And a lot of times I don't have a really good answer for them. So it was interesting to me to actually get some more information about tumor doubling time. So this study looked at 242 liver cancer patients who had 2 imaging studies that were at least a month apart before their treatments, okay? And what they found was, on average, for liver cancer patients, the tumor doubling time was 242 days. Okay, so it took about 6 months for the tumor to double in most patients. So that's why that treatment delay of 60 days may not make a big difference for patients. Now, there's different cohorts of people, okay? So they were actually able to split cancers into 3 different cohorts. About 40% of liver cancers had this indolent growth where the tumor doubling time was 1,300 days. So really slow growing tumors. Another third were this intermediate where it was 181 days, and that's what I was always taught, that tumor doubling time is about 181 days, so about 6 months of tumor doubling time. But that's just a third. But then there's this other 25% where the tumor doubling time is 53 days. Okay, so there are very, very rapid growing cancers, and it's just interesting to know. Now, in terms of which cancer is what, it's hard to predict, but we did see that the indolent growth tumors were more often associated with non-viral hepatitis and larger tumors, so NASH and alcohol, and the smaller tumors tended to exhibit more rapid growth. So the tumors that presented at 2.5 centimeters tended to be the more rapidly growing ones as opposed to the ones that presented late. So we've had a lot of discussion, and I know Paul talked a little bit yesterday about DAA treatment in patients with liver cancer, and does it cause liver cancer, and does it increase the risk of progression of liver cancer? And this was a study that was previously presented that showed that treating Hep C with DAAs did not increase the time to recurrence. However, this abstract that was presented at AASLD actually looked at direct-acting antivirals in patients with active cancer, meaning should we treat them if they have active cancer? And what they found is actually if the patients had active cancer, we know that that decreases the chance of cure, right? But it also, if we were able to cure them, it improved their survival dramatically. So in the patients that had active cancer that were successfully treated, their median time to death in this study was 25.7 months, compared to less than a year, 11.5 months, in the patients that were not cured. Okay, so now not only should we not be worrying so much about DAA therapy causing cancer or increasing recurrence, but our cancer patients with active viremia, we really actually need to be treating them now. And this is so that it can stabilize their liver disease and they're not going to have that competing risk of death that Rich talked about as far as dying from their end-stage liver disease as opposed to dying from their cancer. The proportion of liver-related deaths was cut in half with Hep C treatment from 34% down to 16%. But cancer-related deaths was the same. So it didn't worsen their cancer, but it did improve their liver function. So our Hep C treatment, our Hep C patients now that have cancer, I'm going ahead and treating their Hep C right away. I'm not waiting anymore, okay? We used to wait and see what happened with their cancer. Okay, so that's in the patients who, before they even get to their cancer treatment. So what about the early stage patients in the BCLC, our very early stage patients with small tumors? Right now it's recommended to either go to ablation or resection, and there's been a lot of studies saying that in the small tumors, ablation and resection are equivalent. This was an interesting study that actually looked at what happens to patients after the 5 years after their treatment. So, we have patients that they get their resection, they get their ablation, we're scanning them regularly to see if the cancer is coming back, and we know that recurrence is very common, but it generally happens in the first 5 years. So this study looked at patients and analyzed them for recurrence. And just to remind everyone, and this study was very similar to what we already know, that first 2 years, about 40% of people have a recurrence after their curative treatment. And by year 5, about 60% have a recurrence. Now, I'm using the word recurrence loosely because, as we know, this could be a recurrence of their tumor, but as the later you get, the more likely it is that they're developing a second primary. Okay, your cirrhosis, you develop a cancer, your liver has now shown us it likes to make cancer, okay? So, and I explain this to my patients, like you go to your dermatologist and get a skin cancer off, he's just not burning off one thing, right? He's picking a lot of things off. Paul knows about this. So, these patients have recurrence, but we don't have a lot of data of what happens after 5 years. So they looked at 477 patients in this subset who were alive and without recurrence at year 5, and they continued to monitor them. And what they found is about a quarter of these patients they went on and developed a recurrence after the 5th year. Okay, so even if you hit 5 years after a resection, don't tell your patient that they're cured and they're never going to get cancer again. A quarter of them will get it. This happened with an increased risk in men, your high FIB4, and then if you had an elevated AFP at year 5, meaning you had ongoing liver damage. And these patients need ongoing monitoring, so don't discharge them, keep looking because they have a chance of getting another one. And then just to remind you, we know, again, the recurrence is the issue, and this was looking at ablation versus surgical treatment. And surgical treatment does actually long-term end up in better outcomes. So this was ablation versus resection, and you can see the first 3 years it looks really good, but then you start to have these curves diverge. And that is probably the development of the second primary. After transplant, we know that the curves diverge even faster, and that's because now you're also getting rid of the cirrhotic liver as that competing risk of death. So your small tumors, if they're a surgical candidate, you may want to lean more towards surgical candidacy. If they're not, then resection is still acceptable, but our goal is to try to cure these people whenever we can. Now, hopefully, as we're getting better systemic therapies and we'll have adjuvant treatments, we'll be able to improve these numbers even more. Okay, so then let's move on to the early stage. These are the patients who are within Milan criteria and we're thinking about transplant. So we changed the rule for HCC exceptions in October of 2015. So we're all very familiar with the Milan criteria. You get a MELD exception, your MELD score goes up, you get transplanted based on that. Well, then in October of 2015, the rule was made that the patients would not get their exception until they had a mandatory 6-month wait time. And that was for multiple reasons, including not transplanting people too fast who had those rapidly growing tumors, but also really trying to make sure that we're not unfairly advantaging the cancer patients. So this is an abstract that gave us some information about, well, what's happening after that 6-month rule, because me and the patients are both very anxious during that 6-month time period of what's going to happen to my cancer, why are you making me wait, right? So they looked at 2 groups of patients, the HCC candidates before the 6 months rule and the HCC candidates after the 6 months rule. And then they also compared it across the US, regions in short wait times where they were transplanting people before the 6-month rule really quickly, within a month or 2, medium wait times, and then places like us in California with really long wait times. So what they found is that the 6 months rule, it actually decreased dropout on the wait list. So less patients progressed. More patients actually made it to transplant with that 6-month wait. and it improves their transplant probability, okay? So this looks at the higher score regions, the mid-score regions, so before the 6 months rule, the hazards of mortality with dropout, and then after it went down in both regions, and the ability to get transplanted went up. And I think this is probably because knowing that 6 months wait is gonna happen, people are probably a little bit more aggressive with local regional therapy to keep the cancer in criteria and under control while they're waiting for transplant. The other thing that it did is it actually improved the disparity across the United States, okay? So this is looking at before the 6 month rule here and after the 6 months rule here. And the high score regions, i.e. California in green, the mid score regions, and then the low score regions of conditional mortality with dropout. And you can see a wide variation before the 6 months rule. And then after, that variation really drastically changed. So it actually improved disparity in addition to improving mortality and transplant rate. So even though the 6 month rule is frustrating, it's good for our patients and it's good for the US. So the other thing is downstaging. So we're all pretty familiar with downstaging. So the Milan criteria, as you know, that 1 tumor less than 5, 2 or 3 tumors less than 3, no vascular invasion or extrahepatic spread. That's our transplant criteria. We've now developed the downstaging criteria where if you're beyond Milan and you are within that UCSF downstaging, if you're treated and can get to within Milan and stay there, you can then get your exception points. So the downstaging criteria is a single lesion of less than 8, 2 or 3 between 5 and 8, but 2 or 3 less than 5, but the sum of the tumor diameters of less than 8, or 4 or 5 lesions up to 3 centimeters with the sum less than 8. And Francis Yao showed us in 2015 that 5-year survival and recurrence was very good for that downstaging. So what was presented at AASLD for the first time is we actually now have 10-year outcomes, okay? So 10-year outcomes, we saw that the patient, so green is within Milan. This is what we want to see and what we expect to see. And you can see the downstage patients, they do have a little bit lower overall survival at 10 years, but still very acceptable, more than 50% survival at 10 years. If you're not within Milan when you get transplanted, survival is really not great. So these are patients who either got transplanted too fast or they had a living donor potentially without being downstaged before. You really want to make sure that they're downstaged. And recurrence is also important. So if you're transplanted beyond Milan, you've got a 50-50 chance of recurrence at 10 years. But if you get downstaged, your recurrence rate is between 14 and 20%. So 10-year outcomes now showing that downstaging is an acceptable practice, and UNOS has now made this a nationwide policy. The predictors of failure, if you had more tumors, larger tumors, and if your AFP didn't go down with your treatment, okay, those things would predict that you're not going to make it to transplant and maybe you need to move on to something else sooner rather than trying to get to transplant. And then poor recurrence-free survival once you are downstaged included the maximum viable tumor diameter, this nuclear lymphocyte ratio, which we don't look a lot at, but it can be predictive, and then also your pre-transplant AFP of over 20. You really want to see that AFP drop and be below 20 going into transplant to really improve your chances of doing well in the long term. Also find this interesting, women actually were found to have a lower risk of recurrence after transplant. So we know that there's a male predominance of HCC. We're not 100% sure why that is. There's some thoughts that it potentially has to do with hormones. But this also looked at HCC recurrence and found that overall women have a lower chance of HCC recurrence compared to men by about 25%. So more research is needed to look into this to figure out why, but something to think about. Okay, so intermediate stage, this is generally stuff that we move on to intra-arterial therapies, chemoembolization. Rich had mentioned there's been lots of data, lots of big phase 3 failed studies on Y90, and people still use a lot of Y90. So there were actually 2 different meta-analyses presented at the liver meeting of TACE versus Y90, and polling, about 15 to 18 studies, 15 studies in one, 18 studies in another, to look at this meta-analysis. In both analyses, Y90 was better than TACE in time to progression, 17.5 months versus 9.8 months, also better radiographic response and fewer adverse events. But very similar to what Rich had been talking about with systemic therapy, neither analysis was able to show a benefit of TACE or TARE in overall survival, progression-free survival, or ability to get to transplant. So really, there's some things that look better, but overall, in terms of making patients live longer and making patients get to transplant, the meta-analysis says that they're equivalent. And then advanced stage, Rich already went through extensive information about advanced stage. I just wanted to bring up the Checkmate 040 again. This was also presented a more updated evaluation at the liver meeting. And again, looking at overall survival, that arm A, which is the higher dose of the Nivo, 22 months overall survival, 22.8 months. Okay, so really remarkable with combination checkpoint inhibitors for our advanced stage patients. It used to be, I remember when it was less than 10 months. Okay. Response rates also very, very good. And again, that duration of response with our checkpoint inhibitors. So we're really changing the expectations of what our patients will get when they get systemic therapies. Now, again, I worry about the hepatic immune-related adverse events. Our patients with cirrhosis don't tolerate hepatic autoimmune or immune-mediated hepatitis. That arm A that had the best response, there was 20% of patients that got hepatic immune-related adverse events. Most of them resolved in all of these arms, but not all of them did, okay? The time to onset was about 5 to 8 weeks, and it took about that long to recover also, and patients needed steroids for the most part. So when I'm talking to patients about the immune-related, the immunotherapies, I always warn them there's a chance that you could get this. If you do, you will probably need steroids because a lot of patients get very grumpy when you throw prednisone at them. So you just want to make sure that they're aware of this as a possibility. And then terminal stage, so there was a whole pile of articles about palliative care in cirrhosis. Really, the article that I thought was really interesting and spoke to me was the Prognostic Nutritional Index, and looking at this with survival in patients with liver cancer. So this Prognostic Nutritional Index is a calculation of nutritional markers and inflammatory markers, looking at the serum albumin and the total lymphocyte count. And it's been used to look at preoperative risk in lots of different cancers, but there's never really been much data on it with liver cancer specifically. And what this abstract showed was that patients who had a low prognostic nutritional index, their survival was much worse than in patients that had a good prognostic nutritional index. And this was for multiple different treatments, including TACE, resection, sorafenib, systemic therapy. And it also held true for each of the stages of liver cancer. So when I'm thinking about terminal stage, the recommendation is best supportive care. But now, to me, best supportive care, we have to remember nutritional recommendations for our patients and interventions. So what did we learn? So when we're talking about before they develop cancer, healthy lifestyle characteristics is a modifiable risk factor that our patients can decrease their own risk. We worry a little bit more about your Asia-Pacific Islanders patients. There's some interesting data about carvedilol being protective if it started early enough. HCC surveillance is cost-effective, especially when you're combining ultrasound with AFP, but don't forget to talk to your patients if they have a financial burden. How can we make this better for them? Delays in diagnosis and treatment are common, but it doesn't appear to affect overall outcomes, except potentially in that 25% of patients that have a really rapid tumor growth. And your Hep C patients, you want to go ahead and give them DAA treatment to improve their survival when they have cancer. Once they have cancer, the risk of recurrence, even 5 years after curative resection or ablation, they still have a 25% risk. You need to have ongoing monitoring. Overall, surgical treatments offer a better long-term outcome. That 6-month rule, as frustrating as it is during that 6 months, is good for our patients. And downstaging has acceptable post-transplant outcomes. We still don't have an answer to the question of TACE versus TARE. Combination treatments we know is promising, and don't forget to give all of your patients nutritional counseling for any stage of their liver cancers. Thank you very much.